has looked into the long-term outcomes of hepatitis C positive patients on maintenance hemodialysis. Also, based on Western literature or from the Indian literature, nobody has looked into the natural course of hepatitis C infection, especially in untreated patients on maintenance hemodialysis. With this in background, the main aims of our study was to look at the median duration of acquiring chronic liver disease in hepatitis C positive patients on maintenance hemodialysis, to look at the median survival of hepatitis C positive patients on maintenance hemodialysis, and to look at the risk of mortality in hepatitis C positive patients on maintenance hemodialysis. The study period was lasted from June 2005 to June 2012. The inclusion criteria were anti-HCV antibody positive patients aged 18 years and above with CKD stage 5 undergoing maintenance hemodialysis, control group containing anti-HCV antibody negative patients aged 18 years and above with CKD stage 5 of maintenance hemodialysis. We excluded those patients who had at the time of enrollment with concomitant hepatitis B or HIV infection, those who had congestive cardiac failure, those who had history of CVA, past history of pulmonary tuberculosis, renal allograft recipients with failed graft and later switched to hemodialysis, those who switched from peritoneal dialysis to hemodialysis, and those who had evidence of active hepatitis, that is AST/ALT more than 3 times elevated at the time of enrollment, and patients with underlying malignancy, and patients who had undergone hemodialysis for less than 6 months. The data analyzed at the time of enrollment were age, gender, duration of hemodialysis, cause of CKD, number of diabetics, time to zero conversion, morbidity and mortality. The endpoints of the study was until the death of the patient, or until they underwent liver transplantation, or till they lost to follow, or till June 2012, whichever occurred earlier. Antibodies to recombinant HCV antigens were tested using third generation ELISA. 50% of the patients could undergo nucleic acid testing in our center. The diagnosis of liver disease was basically based on clinical criteria, where the presence of ascites, jaundice or esophageal varices, hepatic encephalopathy, prolonged prothrombin, or based on ultrasound criteria depicting a coarser ecostructure of the liver, or increased motor vein diameter, and splenomegaly. None of them could undergo liver biopsy as it is associated with the increased risk of bleeding in dialysis patient. The data was entered using SPSS software version 18. Categorical variables were analyzed using chi-square test or Fisher's exact probability test. Continuous variables were analyzed using independent t-test. We also did a Cox proportional hazard analysis in order to look at the factors associated with mortality and hepatitis C positive status. The prevalence of HCV infection at our center was 23.5%. The mean duration of seroconversion was 14 months. After fulfilling the inclusion and exclusion criteria, we had 80 HCV positive cases and 51 HCV negative cases, and mean age in both the groups were comparable. Also, the gender distribution, predominantly in both the groups, males were predominant, and it was comparable between the two groups, and number of diabetics in both the groups were comparable. Duration of hemodialysis in hepatitis C positive patient was 46 months, whereas in hepatitis C negative patient it was 40 months, and the difference was statistically significant. We looked into the mortality, where the infection rates and cardiovascular events were found to be higher in hepatitis C positive patients, showing a trend towards significance. However, the incidence of chronic liver disease was found to be significantly higher in hepatitis C positive patients. So the mean duration of developing chronic liver disease in hepatitis C patients or in our center was 34.75 plus or minus 9.2 months. We looked into the mortality and found that nearly 52% in hepatitis C positive and 31% in the negative group had expired, and the difference was statistically significant with a p-value of 0.018. And looking at the causes of mortality, the death due to infections were found to be higher, as well as death due to cardiovascular events were found to be higher in positive group. However, it was not statistically significant, whereas the death due to chronic liver disease was seen in 12% of the hepatitis C positive patients. However, none had deaths due to CLD in negative group. We did a Cox proportional hazard analysis and found that unadjusted relative risk of mortality was 1. median duration of acquiring chronic liver disease was 36 months, and median survival in hepatitis C positive patients was 44 months. In hepatitis C infected patients, adjusted relative risk of mortality was 5.7 times higher, and deaths due to chronic liver disease was significantly greater when compared to those without hepatitis C infection. Thank you. Acquisition of chronic liver disease was around 36 months, and within a year, most of the patients had died. No, sir. This is in untreated patients. We are specifically looking to the untreated patients, where in Indian setting, majority of the patients had financial constraints, and they could not afford the treatment.
Under Rajiv RMC, I think I don't know about the state, everything can be included.
No, sir, in our state, this facility is not there.
What's the any spontaneous remission in patients?
Spontaneous remissions, we have seen, sir, only in specific patients, but we have not included them in this group. No, but none of them had diagnosed.
How often do you screen for hepatitis C?
Only by a few of the patients we do nucleic acid testing. See, every 6 months we screen for hepatitis.
Every 6 months is your weakness. What we have found out is this is CV, ELISA, not a very sensitive marker. People who have at least elevated liver enzymes will go for qualitative CV PCR. It's better. And it will be more useful when you compare the patients who we treated and the patients who we not treated to see whether they could really make a difference in us. If there are no other questions, thank you. Third presentation, Enu George. He will present his paper on complications and outcomes of chronic PD in a tertiary cancer observational class.
Good afternoon, respected judges, professors, teachers, and friends. From Christian Medical College, Dallur, I am presenting complications and outcomes of chronic peritoneal dialysis in the tertiary care center. Peritoneal dialysis has emerged as an important modality of renal replacement therapy and is gaining widespread acceptance. The success of peritoneal dialysis and the patient outcomes are dependent upon various infective and non-infective complications that occur during PD. With regard to the techniques of insertion, the blind percutaneous technique of Tenkov catheter insertion has been practiced widely in centers across India and the world. With regard to Western literature, there are equivalent complication rates compared to the open surgical technique, but data from India is limited to 3 studies. Therefore, we aim to study the complications of Tenkov catheter insertion techniques, to study the incidence, risk factors, and profile of PD-related infections, to determine patient outcomes and risk factors of mortality. We did an observational cohort study of patients initiated on chronic peritoneal dialysis from 2009 to March 2012. The double cup Tenkov PD catheter was inserted either surgically by laparotomy or blind percutaneous technique by nephrologist using the modified cervical technique. Patients who had previous history of abdominal surgeries or there was a suspicion of adhesions were referred for surgical insertion. The rest of the patients were routine underwent percutaneous insertion. The patients are followed up till December 2012. Standard definitions were used from the ISCP guidelines for defining various outcomes. We defined the early complications as those occurring within 4 weeks of catheter insertion and early peritonitis as those occurring within 2 weeks of catheter insertion. Data was collected from patient records and the electronic database of the hospital. For survival analysis, the patient's status who were following up elsewhere were contacted either through telephone or with the help of Blackstar. We studied 178 patients with a mean age of 49 years had a significant patients with comorbidities like diabetes, hypertension, and also coexisting hepatitis infections. The median follow-up was 14.5 months, with a total follow-up of 2,865 patient months, with the in-center follow-up of 1,560 patient months. Of the 178 patients, 26 patients underwent surgical technique of insertion, and 152 patients underwent percutaneous technique of insertion. The overall complication rates were lesser in the percutaneous group, which was showing a trend towards significance, although it was not statistically significant. The occurrence of poor outflow and pericatheter leak were significantly higher in the surgically inserted group, and this was probably because of the higher likelihood of adhesions which were present in the surgically inserted group. The incidence of pericatheter leak is also high in the surgical group, probably because of the longer incision that was used in the surgically inserted group. The rest of the complications were similar between the two groups. We had one patient who developed a mesenteric tear during percutaneous insertion, for which emergency laparotomy was done. The other advantages of using the percutaneous technique are quick insertion, shorter waiting period, and smaller skin incision, and there is a shorter break-in period compared to the surgically inserted patients. There is no requirement of GA or operation theatres, and it is less cost. Coming on to PD-related infections, which is the second aspect of my aim. 49 patients developed PD-related infections, of which 25% were had peritonitis, 4% had tunnel infections, and 3% had exit site infections. These were the total number of episodes. 8 patients had more than one episode of peritonitis. 6 patients with tunnel infection also had associated peritonitis, and 1 patient with exit site had a coexisting peritonitis. The peritonitis rate in our center is 1 in 27 patient months, which when compared to published studies from other centers in India shows that it is better than other centers except the center from Chennai, which has reported as rate of 1 in 75 patient months. Regarding the microbial etiology of the 57 episodes, 19 were culture negative, that is 33%, which is a significantly higher proportion of patients. But we found out that 42% of these patients had received antibiotics prior to coming to our center, which might have contributed to the higher incidence. Of the 34 microbial isolates, we found gram-negative infections were the most common, followed by fungal infections, and then gram-positive infections. This is the microbial spectrum observed. We found that gram-negative were the most common. We also had a fair proportion of patients with candidal infections, and we wanted to look into the factors that were causing this. And we found that out of the 6 episodes of fungal infections, 4 patients were on antibacterials from outside when they presented for culture. So this could have been a co-infection or a super-infection with the fungus, and justifies the need for fluconazole therapy along with the antibiotics. This is an episode-wise bacterial pattern. It shows that among all the episodes, gram-negative infections were common, but the second, third, and fourth episodes had significantly fewer isolates for definite conclusions. Regarding the time distribution of the first episode of PD-related infection, we found that the tunnel infections occurred the earliest at a median of 109 days, exit site infection at a median of 133 days, and peritonitis at a median of 173 days. But overall, we find that most of the first episodes occurred in the first 6 months following catheter insertion. This is the median time to the occurrence of subsequent episodes of peritonitis. The second episode occurred at 255 days, the third episode at a median of 589 days, and the fourth episode at 752 days at widely separated intervals. And there was no episode of recurrence or lapsing peritonitis. With regard to the association of peritonitis, we tested age, sex, early catheter complications, and diabetes, but we could not find any significant association with the occurrence of peritonitis. Regarding outcomes, of the 178 patients, 1/3 died, 1/3 remained on peritoneal dialysis at the end of 3.5 years of follow-up, and remaining 1/3 underwent, about 10% underwent transplant, 9% were transferred to hemodialysis due to catheter removal, and 7% were lost to follow-up. This is the mortality curves for patients who had infection and who did not have infection. There was no significant difference in the survival with patients who developed infection. The median patient survival was 30 months, and cardiovascular disease was the most common cause of death. Regarding predictors of mortality, we found that age more than 55 years, female sex, diabetes, HIV and HCV has higher incidence of catheter loss, and this was found to be a difference of about 7 months. And with regard to the catheter survival organism wise, we found that patients who had fungal infections had a significantly higher catheter loss, and there was no difference in catheter survival between patients who had gram-positive and gram-negative infections. We found that peritonitis, tunnel infections, and fungal infections are significant predictors of catheter loss. The limitations of my study are a significant proportion of patients had received antibiotics elsewhere prior to the first culture, which probably masked the real pattern of peritonitis. The cause of death could not be ascertained for patients who died out of center. The PD adequacy and membrane characteristics were not included in the study and are not included for survival analysis. To conclude, the blind percutaneous technique of PD catheter insertion is safe and has a lower incidence of complications compared to the surgical technique. The peritonitis rate is 1 episode in 27 patient months. Gram-negative infections are the most common. Occurrence of PD-related infections significantly decreased catheter survival. Most infections occurred in the first 6 months following catheter insertion. Old age, female sex, diabetes, HIV and HCV infections significantly predicted mortality. Thank you.
Peaks of incidence of peritonitis, four different intervals observed rising.
Actually, we had only a very less number of corrections in third and fourth episode of peritonitis. So the median time was actually not representative of the population. So that might have been the reason why the median was lost in form.
From Nizam Institute of Medical Sciences.
Good afternoon, everybody. I'm a senior resident, Sriram at the Nizam Institute of Medical Sciences, Hyderabad. My paper is regarding the peritonitis due to non-tuberculous mycobacteria. Peritonitis is caused by non-tuberculous mycobacteria is a rare infectious complication in patients who are on peritoneal dialysis. So regarding the materials and methods, it's a retrospective study involving the 6-step ESRD patients who were initiated on peritoneal dialysis at our center. The study duration was between 1998 to 2012, which is over 14 years, and all patients were using a granule PD solution. Coming to the materials and methods, patients were analyzed with 3 specimens of AD fluid, which are examined for AFP smears and for mycobacterial culture. And coming to the results, we had patients in 2 clusters who developed the peritonitis secondary to non-tuberculous mycobacteria. The first cluster of patients, they were observed in 2005, where we had 3 patients who developed the non-tuberculous mycobacterial peritonitis within 45 days of insertion on the catheter. And the second cluster of patients were observed in 2011 to 2012, where we had about 6 patients who developed this infection within 2 to 3 weeks of inserting the catheter. So this is the prevalence comparison of the various etiologies of the peritonitis, where the predominance is for the bacteria, which accounted for about 50% of the patients. Next, we had about 27% of culture-negative peritonitis, about 15% of fungal peritonitis, and of these, the non-tuberculous mycobacteria, they accounted for about 2.5%. There is a total of 9 cases. So, these are the results of the first cluster of patients who developed the disease in 2005. The mean duration was about 45 days, and all these patients, they had this non-tuberculous mycobacterial peritonitis within the first few days of insertion, and the cell counts are in the range of 450 to 900 cells, with the predominance of neutrophils. And these are the results of second cluster of patients who developed the disease within the first 10 days of insertion of the catheter. And again, in these patients, just like the previous cluster, the counts are within 350 to 840, and again the predominant type of cell
The total prevalence is about 2.5%, of which about 8 were males, and the PD fluid cell count has shown a domination of neutrophils, and in all these patients the peritonitis was refractory, so the catheter development was done. Coming to the discussion, first report of the non-tuberculous mycobacterial peritonitis was in 1983 by Werner et al., who isolated Mycobacterium immunum intracellular and Mycobacterium falciparum. Both these patients died, and autopsy of that patient revealed a disseminated mycobacterial disease. And these are the various non-tuberculous mycobacteria which were reported to cause non-tuberculous peritonitis.